on the prevalence of PAD as detected with the use of the ankle brachial index. And depending on the kind of population that is surveyed, the rates of PAD will vary. So we see here in patients living in a community-based population, a free living population, we see that it could be anywhere from 1.5% in Japan to 5% in the Philippines to 5.2% in Thailand and 15.3% in China. Now, if we look at a little bit the higher risk population of patients who are stable, outpatients consulting at the outpatient clinics of doctors in various practices in the Philippines and the rest of the world, these are REACH registry data. And we see that the prevalence rates have increased a little bit because this population now includes patients with just cardiovascular risk factors and also those with established atherothrombosis, whether coronary artery disease, cerebrovascular disease, or peripheral artery disease. Now, when we look at patients with specific risk factors, zooming into, for example, this population in Iran of end-stage renal disease undergoing hemodialysis, a prevalence rate of 10% is observed. And if we see or we look at populations of patients with diabetes alone, we see prevalence rates in Malaysia ranging from 16% to that of Pakistan, 32%. So the reported prevalence rates may vary depending on the kind of population that is studied or surveyed. And this is already all making use of the ABI. If we zoom into the national data in the Philippines back in 2003, we reported a prevalence rate of 5%. And among these patients with PAD, we have observed that the trend is such that PAD prevalence has been increasing or is higher among females compared to that of males. And the prevalence of PAD likewise increases with age. This trend has also been seen globally. This is an estimated prevalence rate looking at various countries, developed and developing countries, using databases published by these countries. And we can see here that the female population had a much higher increase in the prevalence of PAD in this study. Unfortunately, not all of these patients with PAD may be detected or identified. PAD indeed is underdiagnosed and underestimated. Looking at the NHES2, the national survey, the second edition of it, back in 2008, at an NCR study looking at 1,560 patients or respondents in a free living population, community-based, we see that the prevalence rate of PAD, if the method used is history taking using prior diagnosis, maybe given by a physician, their own physicians, we can only pick up a prevalence rate of 0.7%. And even if we used a standardized, validated, translated Claudication questionnaire, like that used at the NHES study, we can only record a prevalence rate of 1.8%. But if we use the recommended screening tool, which is the ankle brachial index, using a Doppler transducer, with this criterion, then we are able to identify 4.2% of that population with PAD. Therefore, it is really very important to use the recommended tool to identify those patients at risk clinically to have peripheral artery disease. And why is that important? From the REACH registry, and particularly the 1,000-strong population of the REACH registry study in the Philippines, we have likewise shown the trend all over the world in the countries that had been included in the REACH registry, that event rates, adverse cardiovascular event rates of cardiovascular death, MI, stroke, or hospitalization due to atherothrombotic events have increased as we followed up those patients yearly for about a total of 4 years in this Filipino population. Therefore, we need to identify these patients with PAD early enough so we can prevent the occurrence of all of these dire complications of PAD. Thus, in 2016, the Asian Pacific Society of Atherosclerosis and Vascular Disease, acknowledging this increasing trend in PAD, published in many epidemiologic studies and literature worldwide, had decided to embark on this project, the Asia Pacific PAD Consensus Statement Project. And the main objectives were to determine the applicability and the relevance of international PAD guidelines, like the one that was about to be released later that year, the American Heart Association and American College of Cardiology PAD guidelines on the management of PAD patients, taking into consideration the epidemiology, the physician practices, the patient profile, and the patient response to therapy in this Asia-Pacific region. The other equally important goals were to retrieve, of course, and review literature from countries in the Asia-Pacific regions, literature which probably weren't included in the evidence base of the American guidelines or other international guidelines. And lastly, in the process of doing so, to help increase the awareness of PAD in these different countries in the Asia-Pacific region. Therefore, the APSAB executive had created then the Asia-Pacific PAD Consensus Statement Project Committee. And this committee subsequently created the steering committee, consensus panel, and the technical working group with members from different countries in the Asia-Pacific region, as this slide will show. So these had been the people working behind the development of the Asia-Pacific Consensus Statement on the management of PAD from early 2017 to about early 2020, until our publication had been uploaded and shared with the rest of the world. This is, in a nutshell, the process flow chart that we had followed, showing you the different roles of the APSAB executive, the steering committee, the technical working group, and the consensus panel. Looking closely into each of these groups, the technical working group was tasked to appraise the 2016 AHA-ACC PAD clinical practice guideline using the methodology recommended in the EBM PANIS EBM second edition book authored by Dr. Antonio Danz and colleagues. And they came to the conclusion that the evidence and the recommendations made by this international guideline were valid. Next, they decided to convert each of the 88 recommendations or statements of the American Heart Association and ACC guideline into individual research questions. Each of the statements had been assigned to certain members of the technical working group to survey the current literature and more importantly, literature from the Asia-Pacific region, reviewing and appraising each of these studies and reports, and eventually forwarding their recommendations to the consensus panel. Based on the evidence that they had retrieved, they were to either recommend to adopt, revise, or create new statements in addition to what the 2016 CPG statements or recommendations were. Now, the consensus panel, in turn, will take a look at all the recommendations that had been forwarded by the TWG. The consensus panel members will review each of these recommendations, including the evidence base, the appraisal, and meet online using a modified Delphi consensus technique. They will do their deliberation using this methodology. And once 75% of the votes have been achieved, then they could say that consensus had been attained. All of these recommendations as a result of the deliberation will likewise be forwarded to the technical working group for their review. The other Delphi issues that remain will further be dealt with in a face-to-face meeting, and that was done in 2018. As a result of all of this work from 2017 to 2019, 91 recommendations had been developed and forwarded by the consensus panel based on the evidence-based review of the TWG. And from these 91 recommendations, there were 3 new statements that had been created. 57 statements from the ACC-AHA guideline were all adopted in total, while 31 statements had to be revised. And this was due to either a change in the class of recommendation or the level of evidence, while 15 statements had to be revised in order to specify further the indications, the outcome of interest, and to further emphasize the recommendations. Now, these 91 recommendations dealt with the following topics: clinical assessment of PAD, diagnostic testing for the patients with suspected lower extremity PAD, medical therapy for the patients with PAD, minimizing tissue loss in patients with PAD, revascularization for intermittent claudication, the management of critical limb ischemia, and the management of acute limb ischemia. As mentioned earlier, these 16 revised recommendations were due to a change in the COR, taking into consideration concern for added harm, availability or accessibility issues, and economic considerations. And there were 10 statements whose level of evidence had also either been upgraded or downgraded due to database, or more importantly, additional Asia-Pacific literature that were reviewed and appraised. Thus, the entire group created by the APSAV, the TWG, the consensus panel, had all worked together on this, appraising an already existing international guideline, checking for the applicability and the relevance of this international guideline on our own patients in our own practices as physicians in the Asia Pacific region. And we could not have done that without the support of our funding agencies and organizations: the Asian Pacific Society of Atherosclerosis and Vascular Diseases, the Philippine Heart Association, the Philippine Society of Vascular Medicine, the Philippine Lipid and Atherosclerosis Society, and our very own Department of Health. Thus, around September of this year, we had been able to share in international literature the publication of the Asia Pacific Consensus Statement on the Management of Peripheral Artery Disease that anyone can download for free using this URL at the bottom of the screen. Thank you very much for your attention, and likewise again to the Philippine Heart Association for this opportunity to share the highlights on the development of this consensus statement for our patients and our physicians in the Asia Pacific region. Good evening.
Good evening, everyone. For today's PED session, we will be focusing on intermittent claudication. And for my discussion, I'll be talking about approach to the diagnosis of PED, which I will be presenting in two case-based series, highlighting the newest recommendation from the APSAB PED guideline. And then I will be turning you over to Dr. Alahar for the management part. So here's my disclosure. So let's have first the basics of PED. So the APSAB committee defined PED as a chronic vascular disease caused by atherosclerotic occlusion of the arteries of the extremities. It is common in patients with intermittent And who are those patients at risk? So these are those patients who are less than 50 years old with diabetes and one other atherosclerotic risk factors, or could be 50 to 64 years old with risk factors for atherosclerosis, or those patients who are more than or equal to 65 years old with or without risk factors, and those individuals with known atherosclerotic risk factors, I mean atherosclerotic disease in other vascular bed. Now, how do we diagnose them, at least early in the disease process? So that's through ABI screening. Among a symptomatic patient with history or at increased risk of PAD, but without history of PE findings suggestive of PAD, ABI screening is recommended, more so for symptomatic patient presenting as claudication. It's prudent because it's the most cost-effective tool. But the APSAB guidelines do not recommend ABI screening for those patients who are not at increased risk of PAD and without history or PE findings suggestive of PAD. Furthermore, APSAB PAD guideline do not recommend routine screening for asymptomatic atherosclerosis in other arterial beds among all PAD patients since no evidence of benefit were seen. So how do we do ABI screening? Just measure the ankle systolic pressure and divide it with the higher arm systolic pressure using a handheld Doppler. Okay, here. So how do we interpret the result? Just remember the magic number 0.9. So anything below 0.9 is abnormal. And for values that are way above the normal, like 1.4, that reflects falsely elevated ABI, most likely secondary to incompressible arteries, usually from calcified vessels. Okay. Now, Dr. Abola had already presented a while ago the burden of PAD, but let me just highlight to you this particular slide that the prevalence of PAD may vary across the different types of population. So it can be as low as 4.3% among low-risk population and can reach to almost 30% among high-risk patients, especially in this partner study where most patients are elderly, more than 70 years old, or those 50 to 60 years old with history of diabetes or smoking. Increasing age is one of the major risk factors for PAD, and it's highest among octogenarians. And among all the risk factors, diabetes is strongly associated with PAD, followed by smoking. So I just wanted to highlight in this slide that the more risk factor the patient has, the higher is the risk of PAD, more so if the risk factors is uncontrolled, like the higher the blood pressure, the higher the level of cholesterol, presence of diabetes or presence of coronary artery disease, or especially for those patients who are smoker, then the higher is the risk of developing PAD. So this patient commonly present as having intermittent claudication. So now let's go to the role of vascular diagnostics. So here are my objectives: to present a case-based discussion on the common non-invasive and invasive tests used in the assessment of PAD, to review the physiologic basis of each diagnostic test, and to present the evidences behind the abnormal value of ABI in terms of cardiovascular outcome. Okay, so we have several vascular screening tests that can diagnose and prognosticate patients across the variable manifestations of PAD. We have the resting ABI, exercise ABI, segmental pressure examination, and pulse volume recording. Now, for localization and estimation of severe disease severity, we have the anatomic imaging studies like arterial duplex scan, peripheral CT angio, MRA, and invasive angiography. So to give you an idea how each test are being used, let me start with a takeoff case. So we have 48 male, a marketing executive of a well-known airline company. He's a smoker for more than 20 years, came in due to effort-related leg pain. It's actually lifestyle-limiting symptom because these usually present, the claudication usually present in less than 200 meters of walking. So he's a non-hypertensive, non-diabetic. ABI was done showing 0.98. And he also claims to have no anginal symptoms, but with easy fatigability, which was not present months before. Now, if we look at the guidelines, exercise ABI is recommended on two factors. First, those patients who are suspected of having PAD, but the ABI result is normal. Second, these are patients who present with atypical symptoms of PAD. So, treadmill exercise test is actually useful to unmask PAD when resting ABI is normal, or if the patient's symptoms is atypical, such that the common indications for exercise ABI is not just to confirm the presence of PAD, but also to assess the functional severity of claudication. And as I've said, to unmask PAD when the resting ABI is normal or borderline. And it also aids in the differentiation of intermittent claudication versus pseudoclaudication. So now, how do we interpret the result? A positive test is a 25% or greater decrease in ABI after exercise. So now comes the question. So among these patients, these are symptomatic patients, either with claudication or exertional leg symptoms, whose ABI is normal or borderline. Is exercise ABI useful in confirming the presence of PAD? So let me present you two of the data we've seen for exercise ABI. This is a study by Gerningon and colleague, which uses exercise transcutaneous oximetry or TCPO2 in detecting regional blood flow impairment using probes that are positioned on the chest or on the back, and two on each buttocks to detect proximal segment blood flow impairment, and on each calves to detect distal segment blood flow impairment. Now, the data were transferred in a custom-made computer every 5 seconds to automatically calculate the decrease in oxygen pressure from rest. So an abnormal TCPO2 response, I don't know if you can see the yellow line here. An abnormal result is a drop in pressure of below 15 millimeters mercury, suggesting an exercise-induced regional blood flow impairment. So in this study, they've recruited 460 patients and divided the group into borderline AB, to those with borderline ABI and normal ABI. And the result showed that around 60% of patients with borderline ABI were found to have regional blood flow impairment, either in the distal segment, proximal segment, or a combination of both. Now, only around 35% of those patients with normal ABI have this corresponding blood flow, regional blood flow impairment. And take note that blood flow impairment was significantly seen among patients with borderline ABI as compared to those with normal ABI. In this study by Stein and colleague, showing that most of those patients with normal resting ABI values who underwent exercise tests had been referred because of intermittent claudication. Now, interestingly, a study done by Tanaka have shown among patients with borderline ABI as compared with normal ABI. This study have shown that borderline ABI have higher all-cause death, higher CB death and CB events as compared to those with normal ABI, such that the APSAB committee, in reference to our case, adopted the ACC-AHA guideline that among symptomatic patients with borderline or normal ABI, exercise ABI should be done to evaluate the presence of PAD. So now going back to our patient, exercise ABI was noted to be 0.6 from the baseline of 0.9. So that now confirms the presence of ABI. The question is, what do we do next? So the next best thing to do is to localize the lesion and to estimate its severity. Arterial duplex scan is actually one of the common imaging tool used in vascular diagnostics. So it's a useful anatomic test comprised of B-mode imaging, followed by color Doppler studies. So the common indications are as follows. Apart from used for establishing the presence of PAD, it's used to locate and assess the severity of arterial occlusive disease. The following are the rest common indications also. So this is actually a sensitive tool with 92 to 95% sensitivity and also with high specificity. So going back to the patient, duplex scan showed more than 50% stenosis at the left iliac artery. And since this patient presented with a new onset easy fatigability, which was not present before, and knowing that PAD also coexists with other vascular disease, so this patient underwent 2D echo, which showed a moderately depressed EF, 40%, with wall motion abnormalities. So he was advised to undergo coronary angiogram. So coronary angiography showed a tight lesion at the proximal LAD. So since this patient underwent coronary angiography followed by PTCA, then peripheral angiogram is a more prudent option. So on invasive angiography, take note that there's a significant focal inflow disease at the left iliac artery consistent with the symptoms of the patient. So if we apply the guideline, this imaging tool, your duplex ultrasound, CTA, MRA, were deemed useful for assessing for anatomic assessment of the location and the severity of the lesion, especially for patients with symptomatic PAD in whom revascularization is considered. So it was given the strength of recommendation is 1 with level of evidence B. How about invasive angiography? So it's actually reasonable for patient with lifestyle limiting intermittent claudication seen in our patient in whom revascularization is being considered, especially for those patients with inadequate response to guideline-directed medical treatment. So since this patient who is symptomatic, initially presented with low ABI seen on exercise treadmill, and let us see what are the evidences why having a low ABI, we should push our patient to undergo further testing. Okay, so let's look at the evidences. So this study have shown that 63% of patient with PAD have a concomitant polyvascular disease, and CAD is the most common associated problem. Now, looking at the risk of mortality, 2/3 died mostly from cardiovascular causes. Okay. Now, let's look again at the 5-year outcome of PAD. These are patients more than 50 years old. So around 1/3 of these PAD patients will die in 5 years, and the common cause of death is cardiovascular. Around 20% of them would have non-fatal cardiovascular event, and some patients would have this limb morbidity as follows. Okay, so if you would look at this study, the more severe the PAD is, the higher is the mortality, especially if the patient is symptomatic as compared to the asymptomatic one. So this is a meta-analysis of 16 cohort study published in 2008, where they followed up the patient for 10 years. So they used ABI combined with Framingham risk score to predict cardiovascular events and mortality. The results showed that both men and women with low ABI was associated with a significant total mortality. So those data are exactly the reason why CB events is higher among PAD patients. But what makes the condition worse was that they are being treated as a second-class atherothrombotic patient. When screening for CB event is just as simple as performing ABI, which would yield vital predictive data on cardiac event rate and survival data, somewhat similar to the value of EF and LVEDD among heart failure patients, such that the APSAB highly recommend ABI as the initial screening tool for the diagnosis of PAD, not just to save the limb, but also to reduce CB event as the primary goal. So before we proceed to case 2, I'll be turning you over now to Dr. Alahar for the management part. Okay.
Thank you, Dr. Obrado, for sharing the patient's case and paving the way for a discussion on the therapeutic management of a patient with claudication. Good evening, dear colleagues, and this will be my outline for tonight's discussion. I apologize for turning off my video so as not to cover some of the important recommendations in the slides. So Dr. Obrado presented a 48-year-old male smoker with claudication at less than 200 meters. And since the resting ABI was equivocal and he had typical claudication symptoms, it was necessary to perform the treadmill exercise ABI, which turned out positive and confirmed the diagnosis of PAD. Using the Fontaine-de-Riche staging system, the patient is in stage 2 PAD. In order to outline a treatment plan, treatment plan for a claudicant, there are several questions that should be asked. First, what are the goals in managing the patient? Do we manage them by as guidance? The treatment goals in peripheral arterial disease are fourfold. First is to reduce cardiovascular and cerebrovascular morbidity and mortality. Second is to prevent atherosclerosis reducing cardiovascular events, different in major of which had symptomatic PAD of the lower extremities, divided into those who had previous revascularization, previous amputation or lower extremity amputation, with an abnormal ABI or stenosis of more than 50% based on an imaging study. It must be emphasized, though, that only 14% of the patient population came from the Asia-Pacific region, and these were patients who had high-risk symptomatic PAD. There was a significant relative risk reduction of 28% in major adverse cardiovascular events using the combination of low-dose rivaroxaban and aspirin. There was also a significant 46% reduction in male, including major amputation with a combination, and a significant risk reduction of 33% with rivaroxaban, 5 milligrams twice a day when compared with aspirin. The risk of major bleeding defined by an increase in fatal bleeding, intracranial hemorrhage, or non-fatal non-intracranial hemorrhage but symptomatic bleeding into a critical organ was increased by 61%, mostly gastrointestinal in nature in the COMPASS trial, with a number needed to harm of 100. Fatal or critical organ bleeding was not significantly increased. Based on the net clinical benefit outcomes, for every 1,000 patients treated, 27 MACE or male, including major amputations, would be prevented, while 1 fatal and 1 critical organ bleed would be caused over a 21-month period. Because of these, the trial authors concluded that the net clinical benefit favors the use of low-dose rivaroxaban plus aspirin. The reduction in cardiovascular outcomes can also be achieved by risk factor modification, using statin therapy, treatment of hypertension, and cessation of smoking. In terms of the use of antihypertensive treatment, ACE or ARBs have been proven to reduce cardiovascular ischemic events in the HOPE trial with ramipril and telmisartan in the ON-TARGET trial. For patients who smoke, cessation of smoking significantly decreases the risk of PAD per increasing years of quitting smoking. And in terms of glycemic control for patients with diabetes, a systematic review on intensive versus less intensive glycemic control showed that more intensive control was associated with a significant decrease in the risk of amputation. An important outcome in treating claudication is to improve the functional status and quality of life of patients. And xylostazol is effective in improving symptoms and increasing walking distance in claudication with a class 1A level of recommendation. The initial claudication distance is defined as the initial distance at which the patient first experiences pain, while the absolute claudication distance is the distance at which the patient is no longer able to walk because of significant pain. This meta-analysis by Bedenis showed that there is a significant improvement in initial and absolute claudication distance, favoring placebo in this meta-analysis. On the other hand, pentoxifylline is not effective for treating intermittent claudication. The trials comparing pentoxifylline with placebo did not show any significant benefit of the drug on mean walking distance, pain-free walking distance, ABI, or even quality of life. And this meta-analysis by Squires showed that pentoxifylline compared to placebo did not show any significant improvement in pain-free walking distance. Also, in claudication, a supervised exercise program is recommended to improve functional status and quality of life, and also to reduce leg symptoms, a Class 1A recommendation in the consensus. This study by Gomans showed that supervised exercise treatment compared to no exercise, walking advice, and home-based exercise therapy was superior to all forms of treatment regardless of time at 6 weeks, 3 months, and 6 months of therapy. Another recommendation showed that a supervised exercise program should be discussed as an option for claudication before possible recommendation. And this is a Class 1 BR level of recommendation. Exercise rehab is done either in the hospital or in the community. Training sessions in the hospital under supervision are done for 3 times a week for at least 30 minutes per session. For maximal improvement, the patient should undergo the program for at least 12 weeks. And intermittent bouts of walking are done until moderate claudication using a scale is reached, alternating with short periods of rest until the pain alleviates. While the structured community or home-based program is self-directed by the patient after the doctor gives an exercise prescription similar to the supervised approach. To measure the distances or the steps, pedometers are used during exercise. This meta-analysis, published after the NBank meeting, was not included in the consensus, and it compared supervised exercise rehab, home-based exercise, or walking advice to improve claudication distance. Maximal treadmill walking distance improved at 6 weeks, 3 months, and 6 months in favor of supervised exercise therapy. Pain-free walking distance also improved significantly in favor of supervised exercise treatment compared to that of home-based exercise. When supervised exercise was compared with walking advice, maximal and pain-free walking distances also improved in favor of supervised exercise treatment. Comparing home-based exercise with walking advice, maximal and pain-free walking distances in the treadmill did not differ between the two groups. A supervised exercise program should be discussed as a treatment option for claudication before possible revascularization. A Class 1 level of evidence BR recommendation based on the consensus. The CLEVER trial randomized 111 patients with aortoiliac peripheral arterial disease into optimal medical care in blue, optimal medical care plus stenting in red, and optimal medical care plus supervised exercise in green. Only 79 patients completed the 18-month follow-up period and treadmill assessment. The peak walking time significantly improved from baseline to 18 months for both stenting and supervised exercise, but more so with supervised exercise rehab compared to the two treatment groups. There was no difference in terms of the claudication onset time between stenting and supervised exercise, but they were significantly improved when you compared supervised exercise with that of optimal medical care, but not such a significant difference between the stenting plus optimal medical group compared to optimal medical group alone. Disease-specific quality of life scales such as your SF-12, your walking impairment pain severity questionnaire, your peripheral arterial questionnaire physical limitation, and peripheral arterial questionnaire symptoms. The CLEVER trial also showed that quality of life significantly improved with stenting compared to supervised exercise and optimal medical care. But the trial showed that both exercise and stenting had better 18-month outcomes compared to optimal medical care. Both provided comparable durable improvement in functional status and quality of life based on the questionnaires up to 18 months of treatment, which is why exercise should be considered as a primary PAD claudication treatment. So going back to our patient who had symptomatic lower extremity peripheral arterial disease Fontan stage 2B, it is mandatory that we advise the patient to control the risk factors first and foremost by asking him to stop smoking, initiating aspirin to reduce cardiovascular events, initiating statin therapy not only to reduce cardiovascular events but also to improve claudication distance. Claudication distances and improved quality of life will also most likely be achieved with the initiation of xylostazol 100 milligrams twice a day and enrollment in a supervised exercise rehab program. If the patient is at low bleeding risk, addition of a low dose rivaroxaban treatment combined with the therapy that we already have may be considered, especially if the patient does not improve after 3 months of therapy.
Okay, so let's go to case number 2. This is actually the last case. We have Nani, 50 years old female, smoker and diabetic for more than 20 years, came in because of left leg pain during walking at approximately more than 200 meters. Creatinine is normal and HbA1c is elevated. So looking at the risk factors of Nani, she is 50 years old female with history of smoking and diabetes and presenting with leg discomfort with exertion. So if we look at the different manifestations of PAD as recommended by the guidelines, it's always recommended to always perform ABI. So going back to our patient, Nani got an ABI of 1.4. The question is, what do we do next? Remember that one of the limitations of ABI are those with falsely high lower extremity blood pressure recordings due to incompressibility of the calcified vessels, which is actually common among diabetic and CKD patients. Now, looking on how PAD is diagnosed as recommended by guidelines for those patients with an ABI of more than 1.4, it is recommended to do TBI or toe brachial index and pulse volume recording. Alternative is duplex ultrasonography to confirm the presence of PAD. So how do we perform TBI? Take note that there's also a BP cuff and a probe located on great toes. So the toe brachial index is calculated by dividing the toe pressure, but by the higher of the two brachial pressures. So TBI values remain accurate when ABI values are not possible. Why? Because the pedal arteries are less commonly affected by medial calcinosis. So how do we interpret the result? A TBI value of less than 0.7 is considered abnormal, and an absolute pressures of less than 30 millimeters mercury would mean severe ischemia. So if we go by the mechanistic definition of PED using ABI alone, it's actually defined as an ABI of less than 0.9. Hence, the AP subcommittee came up with this question. Can an ABI of 1.4 among patients suspected of having PAD, can it be strongly correlated with PAD? So let's now examine the evidences behind high ABI. So first, I made a diagnostic cut on ABI, comparing it with TBI, specifically among diabetic patients with gangrene. This is actually done by Park and colleague in Korea, and they verified the presence of PAD using invasive angiography. And here you'll see that for ABI, looking at the reliability of ABI among diabetic patients with gangrene, the sensitivity is only as low as 27% with specificity of 89%. But if you would look at the reliability of TBI, no patient with a TBI value of more than 0.6 was demonstrated to have no patient with TBI of more than zero point 0.6 was demonstrated to be having arterial insufficiency, and all patients with TBI of less than zero point 0.6 required balloon intervention with a catheter, rendering the TBI value 100% sensitive and 100% specific. The limitation of this study was actually it only involves very few patients, around 30 limbs. So that's approximately 15 patients. But if we look at the survival data of the different values of ABI, here you'll see that based on the mortality from all causes, take note that high ABI, those with high ABI, has higher mortality rate as compared to those with low ABI. And in terms of predicting cardiovascular mortality, high ABI was noted to be the one with the highest independent relationship with cardiovascular mortality, followed by low ABI, less than 0.9. So in this study, here you'll see that they measured, or they look at the all-cause mortality and CB death according to the different ABI group. So the one in the center is a normal ABI. As you move to the left, the lower the ABI is. And as you move to the right, the higher the ABI is. So they measure all-cause mortality and CBD mortality. And they found out that this particular graph, both for all-cause mortality and CB mortality, it reflects a U-shaped pattern, highlighting an equal influence of low and high ABI outcome, high ABI in terms of poor outcome. Now, even after adjustment of hazard ratio for all-cause mortality and CB mortality, the values remained higher both for high ABI and low ABI in terms of all-cause mortality and CBD mortality, respectively. So in terms of time to all-cause death and CBD according to ABI by value, high ABI is associated with higher all-cause death. For CB death, it's the same for low ABI and high ABI. Now, how about look at the odds ratio of the total and CB mortality. Here you'll see that both the total mortality and cardiovascular mortality was significantly high among patients with high ABI as compared to the lowest value of ABI. Okay, so here you'll see that the cumulative survival was significantly lower for those patients with high ABI as compared to those with normal ABI. So in this study, you'll see that among those patients who belong to the high ABI group, those with elevated ABI group, the presence of PAD was found to be the most important and only risk factor both for total and cardiovascular mortality. Now, this is a very interesting data. This was done by Victor Aboyans and colleague, and it was published sometime in 2008. They look at the relationship between ABI and TBI. So among PAD patients, most of them have a low ABI, some would have normal ABI, and only around 2% of patients have high ABI. But take note that among those patients with high ABI, around 86% of them have a low ABI. Now, looking at the proportion of patients with high ABI, looking at the comorbids, take note that for those patients with high ABI, majority of them are diabetic, around 91%. What about CKD? Data from NHANES indicate that around 24% of patients with creaclearance of less than 60 was noted to have PAD. So the prevalence of PAD is greater in individuals with CKD compared with the general population. This is one of my favorite slides. This is actually very interesting. It's a study done by Arroyo and colleague, published sometime in 2017. They termed it as the Nephrona study. So they look at the prevalence of PAD among CKD patients, and they divided the group to those with low ABI and high ABI. Take note that for those patients with low ABI, there's a significant number of CKD in this group. But if you would look at the stages of CKD, the prevalence of low ABI decreases as the stage of CKD advances. Whereas for those patients with high ABI, take note also that there's a significant number of CKD among those patients with high ABI. And as the CKD advances, the prevalence of ABI also increases. So the APSAB now recommends TBI, when available, should be measured to diagnose patients suspected with PAD when ABI is greater than 1.4. Now, going back to our patient, Nani's TBI was noted to be 0.7. So that now confirms the presence of PAD. The next question is, what do we do next? So the next thing to do is localize and estimate the severity of PAD. So we have segmental pressure measurements with pulse volume recording. It's actually a hemodynamic assessment of the arterial segments of the lower extremities, comparing it with the upper extremities. So take note that BB cuffs were placed on each extremity, a pair above the ankle, another below the knees, and a pair on the lower thigh and then the upper thigh. Okay, so what does APSAB says in terms of segmental pressures and waveform? It is useful in localizing the anatomic segments of PAD, okay, such that the common indications is not just to establish the presence of PAD, but also to determine the severity and the level of the occlusion. Interestingly, it can also predict healing potential of the lesion for those patients who presents with non-healing wound. And it's also important, this tool is also useful in predicting improvement after revascularization and also in evaluating continued graft patency. Okay, so segmental pressure measurements values, how do we interpret it? So a value of more than 20 millimeters mercury between successive cuff in the extremities is an evidence of arterial stenosis. Now, going back to Nani's segmental pressure results, I want to direct your attention to the one with encircled highlights. So here you'll see that on the lower thigh, there's a significant increase in the pressures. And taking note also of the lower extremity pressures, it's actually 200 and 210 millimeters mercury, rendering the ABI falsely elevated. Thus, pulse volume recording was done. So pulse volume recording is a transducer that measures the volume of blood going into the vessel that is being interrogated. So it provides information regarding the intensity of blood flow when BP measurements cannot be accurately done because of a falsely elevated pressures. So for Nani's result, take note that on the left extremity, you have a normal, she has a normal PBR. There's a sharp systolic upstroke, sharp peak, and sharp descent. So in almost all segments of the right extremity. But comparing it with the left extremity, take note that it's already slightly dampened on the upper thigh. There's absence of the dicrotic notch, and also it becomes more dampened at the lower thigh. However, if you would look at the cuff area, PBR, it becomes moderately dampened and almost severely dampened at the ankle area. So with the PBR result, that now confirms, apart from this patient was having PAD, it's the location of the stenosis is located at the femoral area, rendering also the pulse volume recording moderately to severely dampened distally, most likely from the proximal occlusion, probably at the proximal segment, which is at the femoral area, as seen in the segmental pressures. Okay, so the question is, what do we do next? So since this patient is symptomatic, if we need a more detailed anatomic evaluation of the arterial extremities, I mean the arterial segments of the extremities, we have CTA as a non-invasive test that provides detailed anatomical picture of the peripheral arterial segments necessary for pre-op planning or for road mapping purposes. And other than CTA, we have MRA as another highly sensitive, non-invasive tool for localizing area and for assessing the severity of pad. So again, the ABSAB recommends, in terms of imaging for anatomic assessment, duplex ultrasound, CT anatomic location, and severity of stenosis in patients with symptomatic PED, in whom revascularization is considered. So now let's go back to Nani. CT angio was actually done. Conclusion. Okay. The question is, what do we do now to Nani? So I'll be turning you over again to Dr. Alahar for the management part. Okay.
Thank you once again, Dr. Obrado, for presenting us with this 50-year-old female patient with claudication at more than 200 meters, classifying her into Fontan Stage 2A and Rutherford Grade 1 Category 1. Given her history of diabetes, this contributed to the calcification of the arteries, which most likely produced the abnormally high ABI. But the diagnosis of PAD was made because of the abnormal TBI, which is an alternative test for patients with calcified arteries. So similar to the goals and recommendations I presented a while ago for the other patient, these are equally applicable to the next patient since she has symptomatic peripheral arterial disease. But her diabetes allows for more recommendations to be and specifically patients with PAD and diabetes should be counseled about self-foot examination and healthy foot behaviors in order to reduce the risk of ulcer formation or amputation. This may also be reasonable for patients without diabetes, such that we must advise patients to know how to examine their foot at home, and this should also be part of our examination during each clinic visit. Patients with claudication given optimal medical therapy and enrolled in a supervised exercise program are evaluated for symptom improvement after 3 months. And majority of patients will usually have significant improvement the use of 4 medical therapies will guideline directed medical therapy. It can be effective as an option for lifestyle limiting require revascularization therapy, and that both treatments should not be given to patients who are asymptomatic, nor should it be performed to prevent progression to critical limb ischemia. Surgical described as task A or B lesions are suited for an endovascular approach, while bilateral, long, eccentric, and calcified lesions described as task C or D requires surgical intervention. The 2007 task classification has evolved into one that also describes femoropopliteal and infrapopliteal lesions. A more endovascular and surgical approaches will be given in the second installment of the presentation to improve patency after a bypass is of uncertain benefit and potential. The Voyager PAD trial, however, which came out after the completion of the consensus, may result in a new recommendation should the consensus be updated. And in this trial, patients with symptomatic lower extremity peripheral arterial disease who had revascularization were randomized to rivaroxaban 2.5 milligrams twice a day plus aspirin or placebo plus aspirin. In this study, 14% of patients were represented in the Asia Pacific region. Majority of the patients presented with claudication, and 1/3 had a history of critical limb ischemia. Majority of the revascularization procedures were performed for claudication, and majority of these were endovascular approaches. At 3 years, combined rivaroxaban plus aspirin resulted in a 15% relative risk reduction in the primary efficacy outcome of composite of acute limb ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, or cardiovascular death. The principal safety outcome was major bleeding, defined according to the TIMI classification, and major bleeding as defined by the ISTH was a secondary safety outcome. There was no significant increase in TIMI major bleeding, but there was a significant 42% increase in ISTH major bleeding. Defined as fatal bleeding, bleeding into a critical site, a drop in the hemoglobin level of at least 2 grams per deciliter, or transfusion of at least 2 units of blood in the rivaroxaban group. After considering the results of this trial, the clinical bottom line for a patient would be that low-dose aspirin and rivaroxaban may be considered to reduce acute limb ischemia, major amputation for vascular causes, MI, ischemic stroke, or death from cardiovascular causes, having considered the associated risk of bleeding, and the patient is at low risk for bleeding. So how do we treat our nanny, a 54-year-old female with Fontan stage 2A lower extremity PAD? Similar to the first case, we address the risk factors by glycemic control, starting the patient on antiplatelet therapy. We also add on statin treatment, and for the claudication, give silostazole perhaps a structured hospital or supervised exercise program may be difficult for her, so that a structured home-based exercise program may be an alternative. And because she is diabetic, advise her on foot care and examination regularly. And again, because of the results of the COMPASS trial, possibly consider a combination of rivaroxaban with that of aspirin to reduce CV events and limb outcomes if the patient does not respond to the initial medical treatment. So as takeaway, the therapeutic management of a claudicant patient um, is not only to treat the symptom, but more importantly, reduce cardiovascular risk and events, improve the quality of life of the patient, and save the limb. To reduce the cardiovascular risk, we must modify the risk factors. Should hypertension treatment be needed, should be in the form of a RAS blocker, single antiplatelet with aspirin or clopidogrel. But in patients who have low bleeding risk, you may consider low dose rivaroxaban plus aspirin in high risk symptomatic PAD and statin treatment. To improve the quality of life, supervised exercise feasible. So let us take on PAD. And when we do this, we should recognize the patient with high cardiovascular risk, high limb risk, and by doing that, we are able to save a limb and save a life. Thank you.
Okay, thank you very much for that elegant presentation. So, yeah, everyone I think would agree that you delivered an excellent lecture tonight. So thank you very much for our three panelists. And we have learned that PAD is the most underdiagnosed, underestimated, and undertreated of the vascular, of atherosclerotic vascular diseases. Now, despite the known bad outcomes or bad prognosis of PAD. So we at the Council on Peripheral Vascular Disease of the Philippine Heart Association and the Philippine Society of Vascular Medicine see the need really for a heightened PAD awareness, no? And a need for more or better guidance for the management of our patients with peripheral artery disease. So in the presentations, you have seen that in this part of the world, no, so we have some differences, no, and not only racial differences, differences, no, like the availability of the diagnostic and treatment treatment modalities, and even the response of the patients, concise and abbreviated form of reference for us. So stay until the end of the Q&A, because we will not give it now. We will give it at the end of the Q&A. So I now open the Q&A session, and I can see questions already in the chat box, and I encourage our participants to send more questions. We have to grab this opportunity to have our very excellent speakers, the authorities in PED, that will answer our queries. No, all the things that are bothering you, in your clinical practice, we can ask them to our panelists. Okay, so we will start with a question from one of the members of the committee. Okay, from Dr. Eugene Reyes. What are the major differences of the APSAP guidelines from the ESC and the ACC guidelines? So Dr. Abola has presented the new or the differences from the ACC guidelines, but Dr. Reyes would like to ask for further elucidation on these differences, ma'am, as well from the ESC guidelines.
Again, good evening to modified as far as, let's say, strength of recommendation or level of evidence based on recent evidence and a reappraisal of the significance, or uh, the benefits versus the harm uh, that would be possibly experienced by the patients if you give this or offer this option, and more particularly anticoagulants. You will notice that the statements or the recommendations made by the Asia Pacific group had really recommended perhaps a lower strength, or given a statement a lower strength because of the existence of data in the Asia Pacific or even in recent literature of harm that could be significant for the patient population. And that was really one of the considerations for the change in the class of recommendation. In some of these original statements of the ACC-AHA, be it dual antiplatelet therapy, where really no benefit was seen, and only an increase in bleeding. Um, that was appraised or shown, and also that was what do you call this? That was already agreed upon, no, at the very start to compete for that. And they did show, despite an increase in the major bleeding, but none in fatal bleeding, no, or critical bleeding, that the benefit that the patients, the high risk PAD patients would gain for that particular option was more or had a greater weight compared to that. But all in all, you would see, no, all of the antithrombotics, antiplatelet statements, if you review them, would really have were appraised more closely, no, as a result of the potential harm. The other well, the difference with the ESC outright said that they would prefer clopidogrel. And as a matter of fact, during our deliberation, clopidogrel was really seen as over aspirin and other monotherapies, no? In this latest, very recent systematic or meta-analysis, that clopidogrel was shown probably to have the best outcome as far as improving MACE is concerned. But then again, we also had to take up that perspective, the socioeconomic perspective of um, recommending outright clopidogrel over aspirin because of the costs. So compared to aspirin, so aspirin was still preferred over clopidogrel. And the ESC recommended it outright to be the preferred antithrombotic. Excuse me. Um, Likewise, oh, as far as doing imaging, ESC was also more um, aggressive as far as recommending duplex ultrasound as the first line imaging or screening technique to complement the ABI in patients, more so in patients with diabetes. So I think those were the more important ones. As far as revascularization was concerned, was not much in too much quarrel among the different guidelines. Ours actually is a consensus statement. We did not have to do again, no, or reinvent the wheel, and we assessed the existing guideline then for its applicability and relevance to our own practice and our own patients. So it was a consensus gathering.
Thank you, ma'am, for very concise explanation of the differences. Okay, we really appreciate that. Okay, so I will go by the order of appearance in the chat box. Okay, so one question, I will paraphrase this question from Dr. Jomer Mendiguarin. Yeah, so in patients with peptic ulcer disease or peptic acid disorders, of course, clopidogrel will be used instead of aspirin, right? So I think the bottom line here is else beyond clopidogrel. So what if the patients had recurrent events with the clopidogrel? So what else can we use? If ticagrelor is a contraindicated drug, it's the class 3. Patients who had MI patients who had the recurrent MI in the guidelines were recommended to use ticagrelor. So in these patients, so yeah, aspirin, you cannot use aspirin, clopidogrel. So what else beyond clopidogrel? If we cannot use clopidogrel and aspirin, okay. For prevention of cardiovascular outcomes, yeah.
Prevention.
So are you addressing the question to who?
Yes, Dr.
Dr.
Alhar.
Okay.
Yes.
Okay. So
Yes.
thank you for the question. So as mentioned, I think the question was if aspirin cannot be given, can clopidogrel be used
Yeah.
as alternative? So as mentioned by Dr. Abola, already the weight of evidence for the use of clopidogrel over that of aspirin is actually better. Whether we use the antithrombotic meta-analysis collaboration, the CAPRI trial, and even the network meta-analysis by Katsanos, when clopidogrel was compared with that of aspirin, clopidogrel really outweighed aspirin in terms of the benefit of reducing major adverse cardiovascular events. So in the formulation of the statement in the consensus, two factors were taken into account. Number one is the economic evaluation, which looked into the cost effectiveness of the drug. There was actually one Chinese study which showed use of clopidogrel for a long period of time is cost effective, even if you compare it with aspirin. However, that was in the China Healthcare So there are other antiplatelet agents that we can use as an alternative. Silostazole, which we can give for claudication, is in terms of the other antiplatelet like your prasugrel. There are no studies specific to this the symptomatic PAD population, so we cannot use these drugs as an alternative to either aspirin or clopidogrel.
Okay, thank you very much, Elaine. Another question. For patients with claudication and low EF, 40%, and heart failure, what do you give if pentoxifylline is not recommended? So maybe paraphrase is silostazole a significant improvement
Sort of silostazole in particular, it really is a contraindication to give it for patients, especially with functional class 3 to 4 congestive heart failure, and for patients with low systolic function, which is defined as an ejection fraction of less than or equal to 40%. So for this patient who is a claudicant with poor systolic function, then one, exercise rehab will not only target the claudication itself, but also address the eventual heart failure, because it can also, the rehab program can also address the heart failure symptoms. However, if we if this is an active heart failure patient, then we cannot, because the patient might not be able to engage in the treadmill protocol that is set by the machine, which is usually for the graded protocol, and then 2 kilometers per hour for the constant load protocol. So the alternative for that would probably be structured exercise using the 6-minute walk test to determine the claudication distance. And then with that, perhaps personalize a therapeutic option with exercise for that particular patient. With regards to sulodexide, I've read that meta-analysis. Yes, it consisted of 8 trials comparing sulodexide with one placebo and another with pentoxifylline. And there was actually an increase in both initial and absolute claudication distances for as much as 100 meters. That is already significant because in the trials using silosazole, the claudication distance increased by as much as 182 to 200 meters. So unfortunately, when we were making the guidelines for the APSC consensus, we were able to talk to one of the consultants from Australia who was actually excited at that time to possibly include that drug in the recommendation. However, remember our clinical question was the adaptation of the AHA guidelines into our clinical practice. So since none of the AHA recommendations specified the use of sulodexide, we were not able to make a clinical question specific for its use and its applicability on the ABD guidelines. Dr. Abola, would you like to add?
Yeah. So
Yes, more.
I agree that we should always include exercise, any form of exercise, home-based but structured versus supervised. In this patient, um, well, maybe with an EF 40%, the patient is already symptomatic with exertional dyspnea. And maybe I would suppose that the patients would complain first of that even before they get to walk a certain distance. And the other thing about the pathophysiology behind this is that the low cardiac output might be the one causing the claudication. Less perfusion to the ischemic limb. And so improving on the heart, maximizing heart failure therapy would be very important part of treatment in this particular patient. As far as the sulodexide studies are concerned, again, we need bigger studies so that bigger population so that the very good results could be validated. And interestingly, actually, in one of their RCTs, they had measured the profile of the PAD patients, looking at plasma viscosity and the other lipid profiles or values, no? And fibrinogen, and they had shown an improvement in those parameters along with a trend towards decreased mortality, but just a trend. So it would really be very interesting if we have larger study and longer duration of observation for these PAD patients who may benefit really from the use of sulodexide for their intermittent claudication. So yes, so there are other drugs for claudication, but they're not available locally, just in Europe, which is naftigluril, and I don't know if they're still using it for that matter. So yes, that would be all.
Okay. So maybe as in connection with this with the sulodexide meta-analysis, although this is already outside of the ABSAB guidelines, Gay, if you notice, when I looked at it, actually I have read it also when it came out, and I was just intrigued because it said there all of the studies that were included in the meta-analysis were Lyrics, Pluntan, grade 2C. Grade 2C. In your table, I believe you did not include a grade 2C classification for the Fontan in intermittent claudication.
That's the no,
Yeah, yeah, the
updated.
grading.
Baka it might be the Rutherford, sir.
Yeah, but it was written there. It's lyrics spontan grade 2C. So that was my actually. So it's okay. So we will probably look into that now. What is the meaning of that statement? And now let's go to another question. Um, how much is the full course of supervised exercise training, and where can they avail of it?
Well, as someone, Dr. Calatrava, had mentioned, they have it at St. Luke's. We also have it at Medical City. We must remember that these are 12-week long supervised treadmill sessions, 1 hour long, 3 times a week for at least 12 weeks.
Mhm, mhm.
And so all I can say, I think this is more expensive than the cardiac rehab program, because of the use of the treadmill for all of those sessions, no? And for a longer period of time. And even better if 6 months, 3 to 6 months.
Okay, thank you very much. Hopefully, more centers will be offering this modality of treatment. It will be also hopefully be available to the provinces. Okay, so mm, in which specific clinical situation do you recommend the addition or substitution for sulodexide? Okay. So anybody, in which specific clinical situation do you recommend the addition or substitution of maybe I think a substitution of silostazol with sulodexide? Yeah. So
Okay.
when will you substitute silostazol, which is the recommended drug? Yeah. Uh, when will you substitute it with another drug like sulodexide? So maybe in patients who developed headache. So how often do you encounter headaches, and how do you manage this to at least minimizes the side effect of headache in the use of silostazol,
Silostazole.
which is our
So silosa
vasodilator.
Okay, thank you for the question, sir. Silostazole is the adverse event of headache and even palpitations and flushing with silostazole is actually dose related. So if the patient given initially at 100 milligrams twice a day develops that particular side effect, then you can reduce the dose to 50 milligrams twice a day and then wait until the headache subsides before you actually increase the dose back to 100 milligrams twice a day. But again, because in clinics we do see the lower dose also being frequently being given in the trials. As much as possible we wanted to achieve the effective dose of silostazole, which is at 100 milligrams twice a day. Now, for sulodexide in peripheral arterial disease per se, as mentioned, there are limited trials, small ones at that, and then one systematic review of these small trials, except that for this systematic review, the trials are actually quite heterogeneous because the assessment of the claudication distances were different, and some of them were actually on top of supervised exercise rehab, while some were not. So it's very hard to really recommend when to give sulodexide. But in the example of Dr. Uh, Tuazon, where if the patient after exercise rehab still is symptomatic and you've already given silostazole, or the patient has a contraindication to silostazole, I might probably give sulodexide and check if the patient's claudication will decrease. But again, that is just based on a few small trials. One of which is the Suavis arterial trial, which only enrolled around 200 patients, and there was an improvement in arterial symptoms with giving sulodexide compared to that of placebo.
Okay, so yeah, so we really have to, if you start low dose of cilostazol, you really have to up titrate it to the recommended dose of 100 milligrams twice a day, right? We have to emphasize that in the CLEVER trial, the one that you mentioned about optimal medical therapy, it's actually cilostazol 100 milligrams twice a day plus other uh, life lifestyle modifications, no? Optimized lifestyle modifications together with cilostazol and exercise, right? Okay, so now a question for Marge here, Marge. Okay, so so we know that that asymptomatic PAD also carries a high risk for morbidity and even mortality, no, for MI and stroke. So the question here is from from Dr. Julian Amora. Okay, so can we also use exercise treadmill ABI for patients who are asymptomatic with borderline ABI and with risk factors? And yes, and why?
Yeah, actually, the recommendation for exercise ABI is actually among patients at risk for having PAD, where ABI is normal or borderline. So you have to pursue for further testing just to confirm for the presence of PAD. The other factor is if you have a patient suspected of having PAD, yet the presentation is atypical. So you have to perform exercise ABI to unmask the actual PAD symptom or the vascular origin of the symptom. Now, in terms of asymptomatic patient with, the question is asymptomatic patient with borderline ABI and with risk factors, can we also do treadmill ABI? Yes, because if you already perform ABI in patient who is suspected of having PAD because this patient has risk factors for atherosclerosis, yet your ABI is borderline, then by all means, you have to verify the true presence of PAD. Yes, you may do also exercise ABI. And apart from that, stress ABI can also be extended to those patients with abnormal ABI. How? Let's say, for example, you wanted to measure the functional capacity or the improvement of symptoms with medical treatment. You can also extend the use of exercise ABI among patients with abnormal ABI.
Yeah, so yeah, so again, so this is important because some patients may be asymptomatic as later with already with tissue loss, no, or non-healing wounds. So also a common scenario. So we really have to screen also for PAD in these groups. Okay,
Benny?
so
Yeah.
another
Barbara?
question. Yes, ma'am. Oh, Dr.
Yeah.
Apola, will you add something?
Yes, just to highlight the role of exercise testing, no? Not
Yeah.
only will we diagnose ABI or unmask ABI, PAD in those patients with borderline ABI, and even those already with confirmed PAD, we would like, as Marge had said, we would like to document even at baseline the functional walking capacity, and then be able to say objectively after 3 months of treatment of whatever you used, that there is improvement in what the patient was in the first place concerned about, the problem with walking. And we must also emphasize that the protocol, the exercise protocol used for diagnosing PAD is different. It's a 5-minute protocol or less. versus the one that's for functional walking capacity testing that could take as long as 30 minutes just to be able to determine the functional walking capacity.
Okay, so we get several information out of exercise ABI. So that is the reason, ma'am, why TBI was not included in as a screening tool in patients with the risk factors with normal or borderline ABI. Yeah. Well, for March, the Dr. Marge. So is it also the reason why, because of those informations that we get from stress ABI, that we don't recommend, that the APSAB don't recommend TBI? TBI is only recommended in patients with more than 1.4 ABI, right? So in patients with, in this situation, the question in patients who had borderline or even normal ABI with risk factors, so we don't screen for TBI. We go straight to exercise ABI.
Exercise ABI. Yeah. Yes, sir. So the only reason why toe brachial index is recommended, because based on studies, if you have high ABI, the reliability of your resting ABI becomes very low. In fact, it's one of the limitations of ABI. Toe brachial index. Why? Because the pedal arteries are rarely affected by medial calcinosis. So, which is why it's recommended by APSAB committee based on those data to do TBI for those particular patients.
Okay. Another comment here from Dr. Ann Umol. How much can the patient
Just for screening for the presence of PAD, remember it has prognostic information too, like future cardiac event rates or survival data, then all the more that we need to lobby for this particular screening test. And it's cost effective too.
Yeah, and also for rehab, Elaine?
Yeah.
Yeah, because this is, I think, primarily an offshoot of the question about rehab. So how much is PhilHealth covering this kind of treatment?
They do cover it. I'm not sure about the PhilHealth coverage, but if it is not being covered, then definitely we can lobby for that, because we also want to prevent the patients from becoming hospitalized, undergoing a revascularization procedure that would actually be more costly in the future, since if we deal with a restenosis or a stent thrombosis after an endovascular stenting approach, or a bypass graft that becomes occluded, if the procedure was not necessary to start with in the first place, then the cost of treatment is actually larger as compared to just finishing the 12-week program of a supervised exercise. program.
Okay, so another question here. And all these kind of patients. So they are asking if psilocybin will also
Table presented by size them for supervised exercise program. It's different if a patient is now presenting with critical limb ischemia require earlier revascularization after an anatomic imaging completely assesses the type of anatomy for which the patient might require either an endovascular or surgical approach.
so in connection with this questions.
Really should be given uh, once a day for that.
Yeah, so I think we're already beyond our time limit. There's no more question coming out in the chat box. So if you have one last final word to say for each and every one of the three panelists, we'll start with Dr. Abola.
Yes. So again, we are very pleased that we have been given that opportunity to review guidelines, and this would probably apply to any international guideline that in the process, no, of wanting to apply a certain guideline, we was to the population that was studied, and more so with the entire guideline that we choose to follow, that we take a look at its applicability and relevance to our own patients and our own physician practices. And as a matter of fact, as a result of that, we had 31 revised recommendations and 3 new recommendations as a result of the appraisal of the international guideline, not really retracting or diminishing the validity of that study, but really more of the applicability of the
They're able to share information information. And I hope our information through you're actually recognizing